Hi, this is Jackie Placer with a little tutorial to explain my clinical reasoning or my thinking and decision-making processes around chest clearance. It's a little tutorial that I often do on paper, but I thought I'd see if I can share it with you all. Okay, so when I'm doing chest clearance, I usually start with the active cycle of breathing technique. Now, to me, the active cycle of breathing technique isn't 4 deep breaths, breathing control, 4 deep breaths, breathing control, 2 huffs, and a cough. What it really is, and how it was introduced to me, was that it's a system of chest clearance. It's a system where it's a process where you have episodes where you're trying to collect the sputum, and that you need to make sure that you don't hyperventilate or allow the patient, you don't fatigue them too much, so you allow them to recover. So you have recovery periods, and then you repeat with collection periods and then recovery periods, and you keep doing this until the phlegm is ready to come, and then you do either huffing or coughing to expectorate. Sometimes in the literature and sometimes when it's introduced people, it seems to be a very rigid process, that we must always do 4 deep breaths or 5 deep breaths, and it's very, very fixed and rigid in the way that we do it. But I don't think that was the original intent. I think the original intent was that it was just these periods of collection and these periods of rest. And so if we consider ACBT in that way, it makes a lot of sense, and it's something that actually I use and carry forwards into every aspect of chest clearance that I do. I never leave ACBT behind. Whenever I use an adjunct, actually I always use an adjunct in an ACBT cycle. So I believe that for the purposes of research, sometimes, when you're doing a randomized controlled trial, they have to say that it's the same treatment delivered in exactly the same way. And that's where I think maybe we've moved away from that core idea of ACBT as being this flexible collection and recovery approach to this kind of rigid cycle that seems to sometimes get presented now. So hopefully that makes sense as to how we can change and adjust ACBT to meet the individual needs of the patient. Now, probably my basic ACBT for a patient who's not too breathless, who's got a bit of phlegm, would be something like 4 or 5 deep breaths, aiming for a good thoracic expansion. I don't tend to put my hand on the diaphragm or on the abdomen. The reason I don't put my hand on the abdomen is that the closest, I personally feel, and a lot of us do feel like our tummy isn't something we want drawn attention to. It's something I often want to hide. It's rather larger than I would like it to be. And so having somebody put their hand on my abdomen, I would probably feel more uncomfortable with. In addition, people say, oh, well, they're stimulating the diaphragm, but actually the closest muscle is not the diaphragm, it's rectus abdominis. And if you activate rectus abdominis in your breathing, then that's going to create a real dysfunction. It's a muscle of coughing, but it's not something that we would want to activate when we're trying to take a deep breath. So when I'm trying to encourage thoracic expansion and a nice deep breath, I tend to place my hands on the sides of the patient's chest. I would encourage them to feel the movement under my hand and not make any change initially, just feel the movement under my hands and then try to increase that movement with the deeper breath. And I find that for me is more successful. I would encourage everybody to play with different techniques, and yeah, try different ways of achieving that thoracic expansion. One thing that I think it's really fair to say, and I think, if I'm really honest, hand on heart, early on in my career, I really just paid lip service to ACBT. I would just kind of be of the 4 deep breaths and, do that a few times, brigade. And if somebody's deep breaths weren't very good, or if they were very apical, I would probably gloss over that, because I didn't have the skills to be able to change it. I think now, as things have gone on, what I've realised is that, some people have really good body awareness, and they will very quickly be able to adjust and do what you ask them to do. Other patients have very poor body awareness, and when somebody has poor body awareness, or some patients, they might be confused, they might be really quite unwell, and actually they can't adjust their breathing pattern as you've instructed. I think it's really important that, rather than pretending that hasn't happened, and ignoring it, that we acknowledge that we haven't managed to achieve the good thoracic expansion that we hoped, and that we need to try something else. And we can try, what can we do when somebody isn't following instructions particularly well. We can get them up and moving. We can try other techniques like bubble PEP, potentially, if it's not contraindicated. If they can't get up and walking, can they do some upper limb movements and exercises? Some other things that we could try. And that reminds me, I'm going to add something into this chart. Okay, so here we go. I've just added into my mind map, I've just added, when a patient isn't following instructions very effectively, then we might use bubble PEP if it's not contraindicated. Generally, patients can get the idea of blowing. If they're very cognitively impaired, then you might not be able to use bubble PEP if they start sucking. But quite often they will get the idea of blowing, or we can just get them mobilised if it's just a body awareness thing, or following along with some upper limb exercises. I'm now going to just discuss through some different patient situations and explaining my thinking and how I adjust, what my focus for my active cycle of breathing technique is with each one. So first I'll address the post-operative patient. So post-operatively, my focus is really on the thoracic expansion exercises and the supported huff or cough. Most post-operative patients are not significantly breathless, if it is purely post-operative. In fact, they might be a little bit drowsy and a little bit sleepy. So my focus is on getting them to do some nice deep breaths. The aim of the deep breaths is to improve their functional residual capacity. This tends to be reduced post-operatively due to the effects of anaesthetic, particularly if it's gone on for longer than 3 hours, and being on the table. And when they're under anaesthetic, they're only taking very small tidal breaths. They're not taking the natural deeper breaths, sighs, yawns, those kinds of things. They've also a period of immobility as they're recovering. So the focus on thoracic expansion, and then the huff or cough. The reason for the huff or cough is post-operatively, again, effective anaesthetic is the mucociliary escalator is slowed by the anaesthetic gases, or anaesthetic drugs, and it may be that they've got some pain inhibition for their cough as well. So the cilia are moving more slowly, so we need to do the thoracic expansion to try to do more collection, but also they're more likely to have retained secretions because of that natural clearance isn't happening. And then the huff or the cough, we should aim for a supported huff or cough to help with that pain inhibition and to clear it. There is evidence that some evidence around that if you're going to use an adjunct, certainly PEP or oscillating PEP would be the device of choice. PEP, it would be useful, the positive expiratory pressure would be useful in resolving any reduction in your functional residual capacity or resolving atelectasis or collapse of the lung. We often use bubble PEP as our go-to device. We use recycled bottles of sterile water from theatre and suction tubing. So it's pretty much cost negative. There's no significant costs involved. So we tend to use bubble PEP in Hawke's Bay. Now, incentive spirometry is discussed widely in the literature, particularly in America. But in America, they don't have chest physio seeing patients routinely post-op in the same way, I don't think. Respiratory physio isn't, in many of the states at least, isn't part of the physiotherapy profession. They have a separate profession called respiratory therapists. So incentive spirometry would be used in place of physiotherapy. But the literature has meant that it did come in quite widely in many areas where physio was also existing. It is a device with a cost implication. They're about 40 New Zealand dollars or 45 New Zealand dollars each. And my real concern with them is that certainly the device with 3 balls, if ever you hear a doctor or a nurse going around and they say, "Oh, how are you getting on with your incentive spirometry? How many balls can you get up?" The problem is that that's actually encouraging like a really rapid maximal inhalation, and that's actually not what we want to achieve. And if you look at the information leaflet, it does say that the patient should just be encouraged to raise 1 ball for as long as possible. But unfortunately, the instructions of our colleagues, a physio may come around and say, "Oh, 1 ball, just try and hold up 1 ball for as long as you can." But every time the doctor comes around, every time the nurse comes around, and our opinion is not, our instructions are not generally held up against the medical instructions. So if the doctors and nurses are coming around and saying, "How many balls can you get up?" that's actually what's going to happen. So we were finding that there was a lot of really poor practice with the incentive spirometry. So we've actually withdrawn it from all of our wards, and we only have it available. Occasionally we have them available in physiotherapy that we'll use them, but it would be a very rare patient that I would find that was necessary, compared with the options of just doing ACBT or using bubble PEP. So the next situation I'd like to talk about is when a patient is breathless. So when a patient is really, really breathless, it may be that they really can't do 4 deep breaths in a row. And if they were to try, this would be distressing to them, and the quality of those deep breaths would be really, really poor. So there are times when a patient's really breathless when I will ask them to do just 1 to 2 deep breaths, and then focused on breathing control and focused on recovery breathing, I can still achieve the same amount overall, just over a longer time period, and enabling the patients to stay really, really relaxed, as relaxed as possible, and really focus on recovery breathing. Recovery breathing being when you encourage them to slow their breathing as much as possible and focus on the breath out, perhaps through pursed lips. If a patient is breathless, I would encourage them to do recovery breathing, and then hopefully, if they were able to recover their breathing sufficiently, I can move on to breathing control. But when I'm wanting to do chest clearance and I have a patient who's really breathless, it may be that the phlegm is making them more breathless, or the need to clear it is making them more breathless, then what I would encourage them to do is just still focus on that collection, but 1 to 2 deep breaths only. Relax, recover. 1 to 2 deep breaths. Relax, recover. 1 to 2 deep breaths. Relax, recover, and really focus on collecting it gradually over time, getting that phlegm as high as possible, and before we try and huff or cough and clear it. Sometimes when a patient's airways are a bit irritable, they can have coughing fits, and those coughing fits can be really, really exhausting. I mean, once somebody's coughed twice, if they're breathless and so on, once somebody's coughed twice, they haven't really got the air in their lungs to then cough effectively with. So they need to, if you've got 2 coughs, and they haven't cleared it, you need to try to do recovery breathing control, get the patient settled back down, and then go back to that focus on collection breaths, like 1 or 2 deep breaths, just gradually bringing it up higher and higher and higher. Focus on collection breaths, and only huffing and coughing when the phlegm's really, really high and really, really ready. If the patient is having a lot of coughing fits, then I would teach cough suppression. And cough suppression, things like sipping water can help just moisten things down, settle things down a little bit, and sucking. And I heard that obviously we don't want patients sucking lots of lollies, because that's not going to be good for their teeth, and if they've got diabetes as well. So something like sucking grapes, something that will just keep them moist, but that sucking action can act as a cough suppressant. So sipping or sucking to avoid coughing until it's intended. Okay, so that's how we deal with a breathless patient, and we would be thinking about, and I might be doing another tutorial on managing breathless patients, but I would do another tutorial on, I would really be thinking about making sure the patient's in a nice upright position, where their upper limbs are supported, and in a good position to manage their breathlessness whilst they're doing the ACBT. A wheezy patient can be similar to the breathless patient, in that they might not be able to do lots of deep breaths. I would only encourage somebody who is wheezy, and I mean bronchospasm tight wheezy, which gets better with an inhaler. So I would only encourage them to do chest clearance if retained secretions is a current problem. So sometimes it is when somebody's like having an asthma attack, but sometimes it isn't. So I would only encourage chest clearance if they felt that if there was a reason on chest x-ray or auscultation, or the patient was reporting that they had phlegm on their chest that they couldn't clear. So my focus at doing the ACBT would again be on retaining breathing control, Again, I might only do 1 or 2 deep breaths before focusing on breathing control. I would be avoiding coughing. Coughing makes a wheeze, makes bronchospasm worse. So I would be teaching a patient to huff, who is wheezy, to huff, not cough. I'd be wanting them to huff. When you huff, you keep your glottis open, you keep your airway open, and it doesn't encourage the bronchospasm in quite the same way. It would also be really important to time chest clearance with maximum effect of medication, so that hopefully you're doing the chest clearance when the bronchodilators are at their maximum effect. Okay, now moving on to patients with chronic copious sputum. So I'm talking about those patients who might be coughing up, half a cup of phlegm a day, patients with bronchiectasis or cystic fibrosis. So one technique we might use, one device. So these patients might be fine with active cycler breathing technique and positioning and things, but if they need something a little bit more, just to get it up more quickly, more thoroughly, then a lot of the time they'll be using a PEP device, and that would be a really high quality PEP device with a manometer. So they should be they would have a target pressure that they would be wanting to achieve. Generally, for alveolar opening, you're wanting to achieve 30 centimetres of water pressure with a PEP device, but it might be they're just heading for 10 or 20, depending on the situation and their strength. Or maybe using an oscillating PEP device like a bubble PEP or a flutter. Like bubble PEP, flutter, or acapella. Generally, I would give somebody a trial of bubble PEP, and if the bubble PEP was working but just not quite effective, or they wanted something that was a bit more portable, because bubble PEP is not portable, then I would consider purchasing a flutter or an acapella. These devices are more expensive, particularly the acapella. Or the original flutter. The flutter needs to be held upright, so you need to have a patient who's capable of sort of knowing that. An acapella is a bit more forgiving. An acapella is more adjustable, so you can reduce the resistance. So if you've got a patient who's a bit weaker, an acapella they might be able to use more easily than the flutter. But you can get cheaper versions of the original flutter now, and I find it's a little bit stronger. The pressures that are generated, they generate generally about 10 centimeters of water pressure, which then oscillates. So a patient with chronic copious sputum, generally the go-to devices would be PEP, or flutter or acapella, or a combination of those. Some patients have multiple devices. The thing I find with this is, and I find it really interesting, is that often it's prescribed in sets of 10. And in the literature, it's often prescribed in sets of 10. Commonly 3 sets of 10, so you've got 30. I'm not entirely sure where these numbers came from. I think originally just 10 was seen to be a really good idea, because it's easy to remember. But when I consider the basis of ACBT being not to fatigue our patients too much, and some patients can handle 3 sets of 10 fine, but there are some patients, and I do find it quite common, that they're just finding 10 straight off the bat really, really exhausting. And that's why I find it really interesting that we've kind of abandoned ACBT in using these devices. And I kind of think, well, if ACBT is just a system of collection and recovery, why not use your bubble PEP? And this is what I do: your bubble PEP or your acapella or your PEP in that ACBT cycle. So I would get the patient to do personally, if they're not breathless, I would get them to do 4 or 5 um, or 5 breaths through the device, and then recover. And I would get them. Okay, so maybe 30 is the goal. So 3 sets of 10 is what a lot of people prescribe. But I would tend to say, well, if you're finding that really, really tiring, how about doing 6 sets of 5? And often just making that change makes it doable and makes it achievable. And all of a sudden, it's not too exhausting to do their chest physio. So have a little bit of a think about that. Um, when you're prescribing some of these devices. Just because you've prescribed a device doesn't necessarily mean that you need to throw out ACBT. And that brings me on as well to autogenic drainage. So autogenic drainage, as it was originally taught, as I understand it, you're encouraged to do so it's about collecting the phlegm again, and the aim is that you avoid patient getting too exhausted, and it's about collecting the phlegm from different areas of the lung or different levels of the bronchial tree up, and then huffing and clearing them. And what Chevalier said, the guy who, and I'm not an expert, but my understanding is that the physics behind it, if you like, and this kind of relates back to some work I did on manual hyperinflation as well, is that you've got to think about how phlegm moves. Okay, now if phlegm moves, we can encourage phlegm to move by flow, airflow, and so this is like if you've got fluid in a tube, then the fluid in the tube will move in the direction of the greatest flow. So what we want to do is we want our breath in to be nice and slow and gentle, and we want our breath out to be a slightly higher flow rate than our breath in. So it's about doing gentle, active breaths out. So not as forceful as a huff, but if you were to just hold a tissue in front of your face, then it just moves that tissue gently as you breathe out. So it's a gentle rather than a for a huff. The aim often, well, that originally you would do these gentle active exhalations at high lung volumes, and then at medial lung volumes, and then at low lung volumes. So basically what you would do is you take a huge deep breath in, and then you do little breaths at the top, and then you'd breathe out a bit, and you'd do breaths in the middle, and then you breathe out all the way out, and then do at the bottom, when like right at the end of the breath out. The thing is, it's actually quite hard to teach, and patients don't necessarily get it. But what I've discovered is that sometimes with some patients, if they've got a lot of phlegm on their chest, then if you get them to do just a really gentle, if you get them to do a deep breath in and then breathe out really gently, but slightly forcefully, they can feel the phlegm on their chest. They can feel the phrematous. They can feel the vibration in their chest. And what I ask them to do is then do 4 or 5. Again, I use the ACBT cycle, and I'll get them to do 4 or 5 breaths out, just tidal breaths out, but just aiming to tickle that vibration, tickle that phlegm, and then I'll get them to relax and recover. And then I'll get them to do a deeper breath again, all the way in, all the way out, feeling where the phlegm is. And where the phlegm is, I'll get them to again do those gentle active exhalations. And So again, it's the ACBT cycle that I'm using, but I'm using that idea of the gentle active exhalation that came from autogenic drainage. So I do tend to mash the two together. And I find that this makes it, I would only ever do it on patients who had really good body awareness, who had lots of phlegm, who could feel it. But it might be another option that you can try using. And when you see it used, it works really, really nicely. So I tend to not let go of my ACBT, even though I'm using autogenic drainage. And I would only teach it to patients. So I might do the original, the original full-on autogenic drainage if I had somebody who had CF or bronchiectasis who I was going to be able to spend multiple sessions with to really get that technique honed right. But sometimes I can use these ideas of autogenic drainage with patients who have lots of phlegm but might not be in this category, but do have heaps and heaps of phlegm. So that's another thing you can try. Oh, and that brings me along to, and I've just remembered. So sometimes you hear about physios doing deep breaths and then a breath hold, or deep breath and then a sniff. So you do a deep breath in and then a sniff on top. The time when this might be used is generally post-operatively, when a patient's effort isn't fabulous. So I would really only use a breath hold, just give the air a little bit more time to move around, or a little sniff on top, to try and improve my my effort, if I felt that the effort, the patient was not might be inhibited in some way from doing a really good thoracic expansion. So now thinking about some other patient groups. So when you've got a patient who's not conscious, they can't participate in physio, so all of these other techniques that require active participation are out, either because they're unconscious or because they maybe have a neurological condition that means that they aren't strong enough, or don't have the control over the muscle groups required to participate effectively in an active technique, then, or maybe cerebral palsy, something like that. Somebody with learning disabilities, or a child under the age of 2, who can't follow instructions to do blowing games or something, or blow bubbles, or blow feathers across the bed or something. So somebody like this, that's when I would tend to bring in postural drainage, and we often don't actually tip them head down. Sometimes just lying somebody on their side and really getting them over onto their side can be enough. But we might try some postural drainage. And if there aren't any contraindications, and in particular if the patient isn't too old, I would consider that the risks of using manual techniques in somebody over the age of 65 who may well have osteoporosis and things, the evidence base isn't strong enough for them. So I would only use manual techniques in somebody who's young and strong, young and likely to be able to handle them. And I would go gently, of course, to start off with at least. But I might use manual tech. This is the situation where I might use manual techniques, because in any other situation, I really want the patient to be able to use their chest physio to be able to clear their chest when I'm not present. And when you're using manual techniques, you're making a patient dependent. So I would only really use the manual techniques when required. Otherwise, I'd seek another alternative. And if with postural drainage and the manual techniques, if that still wasn't getting it up, then I might need to consider using suction. If they've got an airway in, that's very easy. But obviously, if they haven't got an airway in, I would need to discuss with the doctors whether to put a nasopharyngeal airway and do nasopharyngeal suction. If I'm going to do nasopharyngeal suction more than once, which generally I am, I would personally prefer to put in a nasal airway, nasopharyngeal airway. So that's the unconscious or paralysed patient. Now thinking about the fatigue patient who maybe they've got some neurological condition, motor neurone disease, something like that, or maybe they're somebody who's just really exhausted and unwell and just no longer has the oomph required to take a deep enough breath to do any of these other alternatives. They just haven't got enough muscle power to do that. That's where something like the IPPB, BIRD, or the cough assist is really, really handy. We seem to have a lot of kids with SMA, and cough assist can work beautifully. Oh, and spinal cord injuries and things like that would be using these. And if that doesn't gets it up to a certain point, but not fully, then you might need to progress to suction. But obviously, that's if the patient's fully awake and alert. That can be quite distressing, so giving it a really good go with that. Again, when I use the IPP, the BIRD or the cough assist, I use it in the ACBT cycle. So I would tend to do, sometimes it takes them a little while to get into the swing of it, so I'd do 5 or 6 deep breaths with the BIRD or 5 or 6 deep breaths with the cough assist. I prefer to use it on manual and do some collection breaths rather than doing deep breath in and then straight to cough, as it does on when you set it up on some of the old auto settings. New cough assist is really, really good because you can kind of do both. But I would tend to do it so that I was just doing some nice deep breaths. Again, 5 or 6 deep breaths, and then doing the cough, and then attempting the cough. Rather than with the cough assist on auto going deep breath in, straight to cough, deep breath in, straight to cough. I would try to do some collection before I try to do the expectoration. I hope that this tutorial makes some sense about how you might make some clinical decisions, make some treatment choices for chest clearance. I would say that my peers, my colleagues in Hawke's Bay, align with this very closely, and this is the thinking that I've developed over years of working with other physios in the UK and so on, and this seems to be fairly well. This is how we think, and these are the choices we tend to make. The difficult thing in respiratory physio is that the literature, because of the outcome measures, the lack of outcome measures that we have, effective outcome measures, the literature won't consider one technique necessary to be more effective than another, because we actually don't know that. And that's because the outcome measures that we have, whether you use sputum wet weight, well, a lot of it can get swallowed, or there might be a lot of saliva added. Sputum dry weight, again, a lot of it gets swallowed. They aren't necessarily very effective techniques, very good ways for us to measure. if you're in a big research centre, it might be that you've got some fancy aerosol ways of doing, seeing how things clear from the chest. But in clinical practice, for large scale trials, there are issues with outcome measures. And so, the literature says, we can't really pick one technique over another. And in the textbooks, this isn't really laid out very clearly. Just how to use them, or the theory behind them might be laid out, but not how you pick one over another. So I hope that you find this tutorial useful. So one thing it might be useful actually to talk about would be, how do I analyse whether or not my treatment has been effective? Well, post-operatively, there are sort of outcome measures and things for whether or not measuring whether or not somebody's got a post-op pulmonary complication. There's in the APODs, and there was one done by is it Melbourne, that are really useful for diagnosing post-op pulmonary complications. Usually, it is a subjective assessment of generally the quality of the thoracic expansion, or the quality of the movements, the patient's ability to perform the technique. It may be that you get an auscultation change. If you had some added sounds prior to doing the technique and you've cleared something, you might find there's an auscultation change, but you might not. I would not expect saturations to change significantly unless you had a massive mucus plug that you then cleared. I wouldn't necessarily expect chest clearance to have an immediate effect on saturations. So it's about, when you're evaluating in your analysis, it's about how well they performed it, whether or not they can remember it, whether or not the patient found it effective, and the strength and quality of their cough, whether or not their cough is strong or weak, or their huff is strong or weak, whether or not it was sounded wet or dry, and whether or not you think so if you saw sputum, that's clear, but if you didn't see sputum, if you saw a swallow, so observing closely for a swallow and asking a patient if they might have swallowed the phlegm. Don't forget, swallowing phlegm isn't a problem. The only reason to expectorate really is so that gross people like you and I can have a good gander at it, good look, and maybe send it off to the lab for testing. But if you swallow vast amounts of sputum, it could make you feel sick. But actually it doesn't do any harm. As long as it comes off the lungs, if the patient swallows it, it's only going to pass into the stomach and out the other end. And the patient should be reassured that not expectorating is not a problem, as long as it is clearing off their lungs. So that means that we have to listen carefully, consider the strength of the cough, and consider whether or not it was wet or dry. You can do a peak flow to see what your expiratory flow rate is, to see whether or not it's likely to be strong enough. If you have that available to you, would be another kind of a measure that you could use to see if somebody had a strong enough exhalation to clear. I think that's all from me at this point. I'll see if I can add to this to this series and do some more little tutes like this. I hope you find it helpful. Bye.